Okay, it is due to prolonged immobilization. ALS patient, she is on wheelchair for prolonged period, and there is spastic paraparesis. Okay, okay. This patient with prolonged immobilization, this patient with prolonged immobilization and sudden onset chest pain, dyspnea, tachycardia, and hypoxia. Sudden onset chest pain, dyspnea, tachycardia, hypoxia suggesting of pulmonary embolism. Patients with pulmonary embolism commonly Patients with pulmonary embolism commonly develop small pleural effusion due to hemorrhage or inflammation. The effusions tend to be e- exudative. The effusions tend to be exudative and grossly bloody, and they can be associated with pain due to pleural irritation. Leukocytosis and peripheral neutrophilia may be seen. Leukocytosis and peripheral neutrophilia may be seen as with any acute inflammatory process. Patients with suspected pulmonary embolism should get confirmatory testing, CT pulmonary angiogram. Aspiration pneumonia is common in patients with MS who have valvular symptoms, scanning speech, who can cause difficulty in swallowing. It may cause pleuritic pain, dyspnea, leukocytosis, and exudative parapneumonic pleural effusion. However, lower infiltrate on chest X-ray would be expected. Parapneumonic effusion within 2 days of symptoms is extremely unlikely. Parapneumonic effusion within 2 days of symptom is extremely unlikely in the absence of infiltrate. In addition, the onset of aspiration pneumonia is insidious and often progressing over several weeks, not sudden as patient's presentation, and a productive, often foul smelling cough is common. Okay, hello, are you there? Hello, hello, I can hear you. Mm, Functional residual capacity is decreased. So is it a restrictive lung disease? Because FEV1 is not. Is it normal physiologic changes? She is a smoker. She is a so dyspnea, hypertension. Maybe, but I'm not feeling. Maybe. Is it normal? Okay. Okay. Oof. Okay. Pathophysiology. Pregnancy changes in. Sorry, pulmonary changes in pregnancy. Progesterone induced hyperventilation. Progesterone induced hyperventilation. Clinical feature is dyspnea of pregnancy, increase PaO2 and decrease PCO2. Respiratory alkalosis, lung volume increase minute ventilation, decrease residual volume, increase minute ventilation, decrease residual volume and functional residual capacity, normal vital capacity and FEV1. So normal vital capacity and FEV1. This is important. Okay. These patients' pulmonary function are typical of pregnancy, making her shortness of breath most likely due to dyspnea of pregnancy. Most women experience dyspnea. Most women experience dyspnea during pregnancy due to normal physiologic changes that occur. Progesterone likely triggers a sensation of dyspnea, stimulate the respiratory drive in the medulla, resulting in increased minute ventilation, mostly via increased tidal volume and a slightly increase in respiratory rate. The hyperventilation increases PaO2 to facilitate oxygen delivery to fetus and decrease PaCO2 respiratory alkalosis to encourage unloading of acidic waste from the fetus. Because the gravity uterus, the resting position of the diaphragm Because the gravity uterus, the resting position of the diaphragm elevates in pregnancy, compressing the lower portion of the lung, resulting in the resulting basilar atelectasis causes decreased residual volume and functional residual capacity, as well as a slight decrease in the total lung capacity. However, diaphragmatic excursion is not impaired and actually increases, which combined with increased chest wall expansion allows for larger tidal volume. Although breathing takes place at a lower baseline lung volume, lower FRC vital capacity is unchanged. Okay. Obesity related Obesity-related restrictive ventilation, obesity hyperventilation syndrome, is characterized by restriction of chest wall expansion by excessive mass or thoracic tissue. Vital capacity and lung volumes are decreased and therefore minute ventilation is decreased. Pulmonary thromboembolism can cause ventilation perfusion mismatch, typically increases minute ventilation mostly via increase the respiratory rate. Lung volume is generally unaffected. Okay. Yes. Is is it bronchiectasis? Coarse crackle bilaterally at the base, increased bronchial markings, ring-like shadow, or is it otherwise? Yes, I'm here. My internet is causing problem. Okay. Is it bronchiectasis? Okay. Oh, okay. And this non-smoking patient has chronic production of chronic production of copious thick mucus, occasional streaky hemoptysis, and recurrent pulmonary infections. This presentation is highly suggestive of bronchiectasis, a condition characterized by recurrent cycles of infection, mostly bacterial, and inflammation, mainly neutrophilic, leading to bronchial wall damage and permanent airway dilatation. Dilated airway congest with mucus and mucus leading to bacterial overgrowth. This sets the stage for repetitive exacerbation. The patient's sudden antibiotic response, episodes of foul mucopurulent sputum due to intense suppurative inflammation. Constitutional symptom malaise are common during exacerbation. Erosion into submucosal bronchial arteriole produce hemoptysis, which can be life-threatening. Chest X-ray is not diagnostic for bronchiectasis but can reveal chest X-ray. In the chest X-ray, there is diffuse airway marking prominence and tram traction. Okay. Chest X-ray is not diagnostic for bronchiectasis but can reveal suggestive findings such as dilated and thickened airway, proximal bronchial marking, ring shadow when viewed head-on, high resolution CT scan of the chest required to diagnose bronchiectasis because it clearly visualizes the bronchial wall thickening, tram tracking, lack of distal air tapering, and bronchial dilatation, bronchial diameter larger than adjacent pulmonary artery, a finding referred to as signet ring sign. Once the diagnosis is established with Once the diagnosis is established with HRCT, the underlying cause of bronchiectasis should be identified and treated if possible. Cases include chronic mycobacterial infection, immunodeficiency, hypogammaglobulinemia, and autoimmune disease, Sjogren's syndrome. Yes. Bronchiectasis, pathophysiology, airway insult with impaired clearance, mucostasis, immunodeficiency. Chronic is daily production of voluminous, thick, with or without blood tinged mucus, acute exacerbation, recurrent infection with mucopurulent sputum, frank hemoptysis. Etiology is airway obstruction, cancer, foreign body, and mucostasis, cystic fibrosis, allergic bronchopulmonary aspergillosis, immunodeficiency, decrease immunoglobulin, and autoinflammatory disease, Sjogren's syndrome. Chronic or past infection, mycobacteria, or toxic inhalation. Evaluation: high resolution CT scan of the chest needed for diagnosis, airway dilatation. Pulmonary function testing, obstructive pattern. Investigation of etiology, immunoglobulin level, respiratory cultures, bronchial obstruction. Treatment: address underlying disorder, immunoglobulin, airway clearance, chest physiotherapy, mucolytics, and antibiotics to suppress bacterial overgrowth to treat exacerbation. Okay. 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 Chronic obstructive pulmonary disease encompasses a spectrum of pathology ranging from chronic bronchitis to emphysema, eventually eventually leading to chronic. Yes, chronic obstructive pulmonary disease encompasses a spectrum of pathology ranging from chronic bronchitis to emphysema, eventually leading to non-reversible airflow obstruction. Pulmonary function testing with decreased FEV1 by FBC ratio and decreased FEV1. The resultant air trapping can lead to hyperinflation, seen as diaphragmatic flattening on chest X-ray. The patient has classic presentation of COPD with predominant chronic bronchitis phenotype. Chronic bronchitis occurs due to irritant-induced mucosal inflammation, respiratory inflammation, epithelium metaplasia, mucus hypersecretion. It is defined as productive cough for more than 3 months over consecutive 2 years, with or without airflow limitation. By contrast, emphysema involves proteolytic destruction of the alveolar wall, Some distinguishing features include the following. Some distinguishing features include the following. The DLCO, the diffusion capacity of the lung, DLCO, which measure the gas transfer of the alveoli and pulmonary capillary blood, remains normal in chronic bronchitis, but it is decreased in emphysema where destruction of the alveolar wall reduces the alveolar gas exchange on surface area. The chest X-ray in chronic bronchitis reflects airway inflammation, including prominent thickened bronchovascular marking. In contrast, chest wall finding in emphysema reflect obliteration of the alveolar septa and include decreased lung tissue density and bulla. Management of two subtype groups is similar, although the distinction can be useful in preventing advanced case. For example, patients with frequent exacerbation of chronic bronchitis gain more benefit from mucus clearance, chest percussion, and anti-inflammatory agent, inhaled corticosteroid. Can you give me 5 minutes? I need to restart the internet.